evening, and thank you for joining us, and welcome to Parenting a Child with Spina Bifida and Hydrocephalus, Navigating 101 with Amy Mullin, who is a registered nurse. So your hosts for this session are Hydrocephalus Canada and the Association de Spina Bifida et de Hydrocephalus du Quebec. The event is generously sponsored by the Sick Kids Foundation and Amici Catheters. I'm Shauna Bodway, the Director of Programs and Information at Hydrocephalus Canada, and I will be the moderator for tonight's session. Tonight's event will focus on the different types of spina bifida, secondary conditions, hydrocephalus, neurogenic bowel and bladder function, and tethered cord. You will also hear about tips and strategies for treatments and care regimens and gain a deep understanding of the developmental steps of raising a child from birth to age 12. Please note that the speaker is not recommending any specific course of treatment for spina bifida or hydrocephalus. Always speak with your healthcare providers about your course of treatment to ensure it is right for you or your child. Our presenter today is Amy Mullin, registered nurse with a Bachelor of Science in Nursing. Amy is the ambulatory care nurse for the Spina Bifida Spinal Cord Injury Clinic at Holland Bloorview Kids Rehabilitation Hospital in Toronto. With 16 years of nursing experience in pediatric rehabilitation and specialized orthopedic development, her passion is helping children with disabilities thrive and live their best lives. She is actively involved in quality improvement for the prevention of pressure injuries in the community, as well as family-centered care. By taking a solution-focused approach to care, she teaches and educates clients and families on the importance of reaching goals to live a fulfilling life full of possibilities. Welcome, Amy. We're so happy to have you tonight.
Thank you so much, Shauna. So as Shauna mentioned, my name is Amy Mullin. I am a registered nurse with the Spina Bifida Clinic at Holland Bloorview. We actually see our families come from all over Ontario, and it's, I would say, the largest Spina Bifida clinic in Ontario. So we'll just get started. So I just wanted to do an introduction because this is really the motto we kind of go by. You treat a disease, you win, you lose. You treat the person, guarantee you'll win no matter what. And so we just want to, first and foremost, see your child, who they are, all the amazing things that they can do. And again, we strive to be solution focused. So celebrate the positives. So today's presentation is just to present the health information so you're informed. Spina bifida is complex, and so I will be covering a lot, and just please know that this information, as Shauna said, it's I'm not offering any treatments, but just to give you again provide that education so you're informed and you can make informed decisions when it comes to the treatment of your child. All right, so I work very closely with the developmental pediatrician. And so when looking at, your child as a whole and who they are, we tend to look at these certain things. And so the emphasis on those who were historically excluded. So we're about inclusion and how we can achieve that. So what works best for, the child, what works best for the family in any given situation. The advocacy piece, both in the medical world and in the community, it's important, again, for you to be informed, to be educated, so that you can use your voice to help advocate for your child. And you can show your child, lead by example, to use their voice to advocate for themselves as well. So I really encourage you to become educated with reliable resources. I know Dr. Google is tempting, but please make sure that your sources are reliable and that you have people that you trust and they're knowledgeable, that you can have conversations with. So your GP, pediatrician, specialists, Hydrocephalus Canada, you know your child best. And so, if you're having, I always tell parents all the time, if you're having a feeling about something seems not right, something seems off, speak up, advocate, and let that be known. For the family-centered care. So again, we see the whole child, and that includes not just the child, but the family, their environment, the resources available to them, and so on and so forth. With optimizing the function and integration, we, you know, when you see the whole child, you see that first and foremost, they're a child at whatever age they are. They want to be included just like every other child, to go to school, to play sports, to have hobbies, to have friends. And so there may be, some barriers along the way, but that's part of the journey, is that we have ways of trying to overcome those to help your child have all of those things, and lead, a happy, fulfilling life, which is, of course, what you want for them as well. And so, part of that, there is, a cultural impact on development, perceptions of disability that, also need to be taken into consideration. Again, it goes back to seeing the whole child, the family, the whole picture, when providing care and thinking about different treatments. And then close collaboration with an interdisciplinary team. So this is the part that I find is really helpful in our clinic in particular, because spina bifida can encompass a lot of different secondary conditions, which we'll discuss later in the presentation. And so it helps to have that interdisciplinary team to help with those different things. For instance, a physiotherapist can assist with the gross motor functions, while the occupational therapist with the fine motor, or for wheelchairs with equipment. We in our clinic, we have assistants from or consultants from sick kids in urology and orthopedics, and we also consult with neurosurgery there as well. Also in our clinic, we have available to us psychology, social work, speech language pathology, a nurse practitioner so developmental pediatrics sees kids from birth to age 13. And then we have a nurse practitioner from age 14 to age 18. And that piece of her role in that piece of the clinic is for transition and for adolescent medicine, for all of those things, that come along again, that every preteen and teenager experience. We want to address those specific needs that they have as well. All right, so just a bit of Spina Bifida 101. We know that it occurs before birth. It results in the incomplete formation of the spine and the spinal cord. And so it results in varying degrees of a possible paralysis or sensation, and then bowel and bladder function are quite common. And then the others that listed below: vision, hearing, learning disabilities. I will say that no child is the same. And even if we have, children that will have maybe the same lesion, of a myelomeningocele or a lipomyelomeningocele, it doesn't mean that they are going to behave like a peer that has the exact same neural tube defect. So all of our kids are unicorns, and we again see the whole child and work with the whole child. So with spina bifida, the average is 2.6 in every 10,000 babies in Canada. So as I mentioned earlier, it falls under the category of a neural tube defect. And so there are different factors that have been identified in that. So with the formation of the brain and the spinal cord, it develops in the first month. And so oftentimes before, the mother finds out that she's pregnant, the neural tube has formed. And so when it doesn't form properly, that's when spina bifida occurs. So the bone, muscle, skin, it can't form around the spinal cord where the tube is open. And so that causes, depending on if it's a myelomycele, a myelomeningocele, or a lipomyelomeningocele, is the degree of how the cord is affected. There are photos later on, so it's easier to understand. And in that, because the spinal cord is filled with all of these little nerves, is where the other secondary conditions come in. So as I said here, the higher the seal, the greater the potential for damage. So you have them along the spinal cord at, your thoracic level, your sacral level, and lumbar level, so on and so forth. So here are the photos that I mentioned. And so those are the different ways that the spinal see. So for the spina bifida occulta, your cord isn't really affected. We don't see many kids with spina bifida occulta in our clinic. They rarely are symptomatic, and it's not until they're symptomatic that we will see them. For the meningocele, the kids with the meningocele, we do see again some kids, but mainly we see the kids with myelomeningocele and lipomyelomeningocele. And so with the meningocele, it's just the spinal fluids. You can see the yellow, that's the cord, is not involved in kids with a meningocele. And so when the cord isn't involved, there isn't as much nerve involvement. With the lipomyelomeningocele, there's essentially that fatty tissue that is over it. So the spinal cord could still be coming through there, but it's got the fatty tissue. And then for the myelomeningocele, you see the spinal fluid as well as the spinal cord and the nerves. Now, kids with a myelomeningocele, it's considered an open neural tube defect. So with a lipomyelomeningocele, it's closed. That fatty tissue covers and it's not exposed to the outside. With a myelomeningocele, those spinal nerves and the spinal fluid, the sac, are exposed to outside. So it's open. And when they're born, the area is closed. So the skin is stitched back together and makes it closed again. So it's not exposed to the outside. So again, I gave a bit of an explanation, but this just shows in more detail. I like to show the first one with all four, just so that you get an idea of the difference between them. And then we can go into a little more detail here. So a myelomeningocele would be considered the most severe form of spina bifida because the bones don't close around the cord. So the vertebrae don't close, and so it's able to come out. And again, you can see that the nerves are there and it's exposed to the outside. With the meningocele, again, less severe because you will have the spinal fluid sac that's out, but you don't have the nerves that are necessarily involved. The sac itself is often covered by skin. And so it's not always exposed to the outside either. So with the lipomyelomeningocele, you can see this little one with the little kind of like poof on their back. And again, that's the fatty tissue that is covering the opening of the tube defect. So there can still be damage to the nerves that happen because you still may have the nerves coming out, but instead of being exposed, it's covered by the fatty tissue. And so, whereas with the meningocele that's covered, this one is covered, but you can also have symptoms, like I said before, about the nerves. So you can have symptoms where the nerves are affected. And so you may have, some of these that are listed below. So The one I guess we would see most often are the muscle weakness of the legs. There can be some foot deformity and that loss of sensation. So there could be just patches where the child can feel, and then patches where there's no sensation or a decreased sensation. Back pain isn't as common, but then the urinary or fecal incontinence is common in kids with lipomyelinogeal. Oh, I think my slides got mixed up. Sorry about that, guys. Okay, so I know this is a very important slide for parents on here who want to know about these developmental milestones. So again, with the developmental milestones, you have to look at the kids just making a way for any barriers that come along to help them with those. So if you're looking at, the 1 to 2 months where kids are holding their head up on their own. So if the child has difficulty with head control, that's when we get PT involved. They can assist with exercises that you can do daily to help strengthen their neck muscles. No child likes tummy time. No child likes to do that. We do find that our kids who have had any length of stay in the hospital, they are going to be a bit more delayed in their milestones just because that hospital stay will set them back a bit. If your child is in hospital, we do find they will favor one side. So, and that will be the side that they receive care on. So, if they're on their stomach, when they lay on this side, you'll see that they're more prone to do this. And so then you work with their neck muscles to try to get them, to be able to do this as well. So it's just little things like that, that you work with them every day to help strengthen, whether it's their neck muscles, their tummy muscles, practicing rolling, all of those things is, you just continue to practice every day and you work with a therapist for that. We do have infant development services as well that will, before the pandemic would come to the home. I'm not sure if the community services are back to going in home or if they're doing virtual, but they also are a really good source of knowledge for these tricks that, will help strengthen and help your child get to those developmental milestones. So for 6 and 7 months, when a child can sit on their own, again, a child with spina bifida or hydrocephalus, we can use different things to help support them, to build up that trunk support, to build their neck so they can hold their neck, and then their trunk so that they're not wobbly. But then there's something called a tripod sit where they will sit with their legs out, but then their hands in front of them to help support them. And again, it's all about building up that core strength. For 8 to 10 months, when a child for the milestone is expected to crawl and start exploring their environment. We have different ways for kids who may not be able to crawl to get around. So the little caster carts, and we have some little ones that absolutely love their caster carts. It's essentially, I should have put a picture on, but it's very low to the ground. It's got big wheels where they can roll around, and they just love exploring. They want to get from point A to point B, and that's how they do it. We also have kids that will do like a commando crawl, where they use more of their upper body to get around, and or they will be sitting and they'll just bum scoot around. They will find a way. So encourage them, if there's something they're interested in, set it, out of their reach, have them to go get it, and encourage them to build these strengths and to find their own way of achieving it. So for 12 to 18, when for a milestone, a child begins to stand or walk. For our kids with spina bifida hydrocephalus, they may be need a standing brace. I will say that before a child stands, we don't really recommend the ankle foot orthotics or the braces. The orthopedic surgeon, for some reason, may for different reasons, but we usually don't, simply because when a child is learning to crawl, sometimes that can impede them, and so they the AFOs are clunky, and they don't like to have them on when they're trying to explore and try crawling. And if your child is, doing well with that, we don't want to stop that learning. So we want to encourage that. But when the child starts to stand, we do want to make sure that they are well supported. As we'll get into later, there can be muscles on one side that are really tight, and then muscles on the other that are more flaccid, that are not as tight. And so the tight muscle is going to pull, which can cause them to stand on the outside of their foot or the inside, whichever, happens to be the tighter of the muscles, and we can see pressure sores. So that's when we introduce bracing to make sure that they're standing with good support so that they're standing safely. So for 18 months, when a child begins to run and jump, if appropriate, for our kids, we may suggest that they could try a short ankle brace or walker and crutches. So it just helps them to be able to maneuver and get around a lot more and keeps them safe. In schools, I know that's later on, but we, do encourage those things if the child is not as stable as we would like, because once they do get into daycare and then on into kindergarten and so on and so forth, where you do have a lot of kids running around, we want to make sure that they're safe. So if they're a little wobbly on their balance, having a little walker there or some crutches, canes to help them to maintain their balance is a really good safety option. And then for 3 years, when a child can ride tricycle and walk up and down stairs. So again, our kids find ways, and we have adapted equipment that we can introduce, little bikes, little trikes, like I mentioned, the kiddie carts that they can zoom around in, and then many of them will scoot up and down the stairs. So they find a way. All right, so when we're looking at the challenges that may come along, we have to look at the things that we see that our families bring to us that they consider challenges. So the continence piece, making sure that they're socially continent, especially when they start getting into school age. We really want to look at that for social and inclusion and participation. So they're linked. When we're looking at a child's quality of life, families will tell us it's not really the mobility as much as it is this social continence piece, so that they can have friends, so that they can have relationships, so that they can, get a good job down the road. All of those things play a part in that continence piece. As they get older, when I was talking about the adolescent clinic and, talking about sexuality and, if there are any challenges that come up with that, whether it's sensation, whether it's continence, all of those things, and we work with them to try to overcome any barriers that there may be. Obesity, we do see obesity in some of our kids, just because if they're not as mobile and not as active. There's also, we'll go into it a little bit later, something called a Chiari malformation, which can cause our kids to be really sensitive to certain textures of foods. And so they're very, very picky eaters. And as a parent, I totally understand. Sometimes you just want to, if your kid will eat pizza and that's all they'll eat, you give them pizza. And so we find though that the diet is not always the healthiest, but again, we just try to give those kids, what they'll eat, the nourishment that they'll eat, and try to find, a different way to get them active. The living well, transition, again, come into the piece of the nurse practitioner later on in the adolescent clinic when they're transitioning out of pediatrics into the adult world, because the adult world is totally different. And so that's when we really want to encourage independence, because, you know, a challenge with the adult world is that you have to be on top of everything. They're not going to call you with a follow-up to your next appointment. If it's missed, it's missed, and that's it. You can go years and years without, you know, seeing someone, and then realize, oh, I need to see my urologist, or I need to see my, you know, oh, I have this wound and I need to see, you know, someone, but you're not connected. And so the transition piece is really huge in maintaining that constant continuity of care that you, your child will be responsible for. Oops, did I go too far? I did. There we go. Okay, so for the cognitive piece, we do find that many of our kids will need an IEP, or an integrated education plan. The splintered intellectual skins, that's supposed to be skills, my apology. And then the inconsistent attention and executive function. So the executive function is controlled in the frontal lobe of the brain. And many of our kids will get a diagnosis of ADHD. We do psychoeducational assessments for them, and we'll come back with the attention deficit or hyperactive, so ADD or ADHD diagnoses. For the neurosurgical piece, hydrocephalus, and the kids that either have shunted hydrocephalus or unshunted hydrocephalus, or that get an ETB-CVC, and we'll talk about that one a little bit later. Along with the neurosurgical piece, again, there is something called a tethered cord syndrome, and then that sensory loss. For the on the orthopedic side, we're looking at scoliosis, like a scoliosis. For the musculoskeletal abnormalities, usually in the feet, but we do have some kids with hip dislocations, gait disturbances, and then some weakness. As I mentioned previously, the urology, the bowel and bladder, the incontinence and the social impacts. For the skin, is really, really important, just because of that decreased sensation, that you're encouraging your child and you're working with them to do daily skin checks. So when they take their shoes off at the end of the day, to look at their skin, and if you're seeing any red spots that don't go away after about 20 to 30 minutes after they've taken their shoes off, you want to watch those spots, because those could be areas that the skin will start to break down. It is so much easier to prevent a wound than it is to try to heal a wound. Because many of our kids, with the decreased sensation, there's also a decreased healing time. And so prevention is always key. For the gynecologic, in our girls with spina bifida, we do see that precocious puberty can happen. So you could see signs of puberty happening earlier. And those are things that you would just want to mention to your doctor. All right, so now all of those things that were in that list, I'm just going to go into a little more detail. So for the hydrocephalus, approximately 85 to 90% of individuals with spina bifida will also have hydrocephalus. So as you guys probably know, it occurs with that excess cerebral spinal fluid builds up in the ventricles, and then that enlarges the ventricles. And so kids will often, and these are also signs that you would look for if, there was any pressure building. So the weakness, the spasticity, headaches, nausea are a big one. Shaking can also happen. The visual problems, where the shunt is, depending on what side it is, you'll see like the little tube. You may see swelling at that site. You may see redness. It may be hot. Again, signs to seek treatment. And then at the end, constipation sounds like a strange one, but actually when you have the pressure in the brain, it affects every other function of the body. So if it's not a norm for your child specifically, if that's a change, we want to know about it, or your provider wants to know about it. So when I was talking previously about the VP shunt and then the ETV CPC, so for hydrocephalus treatment, there are two different options. There is the VP shunt, which directs the cerebrospinal fluid into the abdomen, so via tube that they surgically put into the ventricles, which drains down into the stomach. There's a photo there on the right. And then there is the ETV CPC. And so I always have to write that down. So that is the, hold on. I thought I had it in my slide. Endoscopic third ventriculostomy and choroid plexus cauterization. That's why I do the abbreviations. So essentially, that one allows they cut a little hole in the third ventricle. I believe they go up through the nose, cut a hole, so it's not an open surgery. They just go up through the sinus, the nasal cavity, cut a hole in that third ventricle, and it allows the CSF to drain normally. Because essentially hydrocephalus is just an imbalance between how much CSF is produced and then how much is absorbed in the blood, and it just creates that pressure. So oftentimes they can do it with the ETV CPC, and then the child doesn't have to have the shunt. Again, signs and symptoms of shunt malfunction, very, very important to know and to catch them as soon as they're happening. Last week, we just an example, we had a little one, she's 10 months old, and mom called me and said, she's acting fine, but she just will shake like this, and then she stops. She's eating, she's drinking, she's giggling, she's acting totally like herself, but she's just started this like shaking, and not her head, but from her neck down, her whole body would just shake. And then she would stop. It would be a few seconds, and then she would stop. And so mom had called me, I think around 3, this had started around 12. And I said, this is different than her normal. I would recommend that you take her, to the emergency room, because she had tried to call the neurosurgeons, and they were not in the office at the time, and so they couldn't answer her. And so she went to the hospital where her neurosurgeons are. They did an MRI, and sure enough, there was swelling in the ventricles, and they needed to revise her shunt. And so any changes, you contact your medical provider. It's important to catch these things really early. So the Chiari-2 malformation that I mentioned with the sensory, so kids will often have like a gagging, choking, vomiting just with certain textures. They can't really tolerate those textures. And so with that, what happens is there's the pulling on the cord, which pulls the brain stem lower than it usually is. And so that compresses the upper part of the spinal cord in the neck, because there's an opening in the skull at the base of the skull where the spinal cord goes through, and it kind of compresses and pulls it through that opening in the skull. As I mentioned, there are some of the signs and symptoms of the Chiari, and it mainly affects that oral part. Now with tethered cord, we find tethered cord can happen at any point, but we do find that it does happen more often during growth spurts, because the spinal cord itself isn't attached to anything. It's just free flowing and sits in the CSF. And if it attaches and you grow, it stretches, and the nerves are stretched, and they don't like to do that, and you will hear from them. And so just like with the hydrocephalus, if your child has their norm, say with their bowel and bladder, and there's a change that happens in the bowel and bladder. They start having more urinary tract infections, or they start having more accidents from either bowel or bladder. That's different from their norm. It could possibly be a tethered cord. Back pain. We don't really see a lot of back pain in kids. So if your child is all of a sudden complaining of back pain, I mean, if they've gone on a long walk, or, you know, when they say, oh, my back hurts a little bit, but it goes away, we're probably good. But if there's this consistent, you know, oh, my back hurts, or my leg hurts, they're falling more, you're seeing a change in their foot shape or the way they're walking, that could be tethered cord, and is something that you want to contact your physician about. So as I mentioned before with neurogenic bladder, essentially it's where the signal that's running from the brain down into the spinal cord to the bladder, it's disrupted by the neural tube defect. So all of those nerves that are affected, it doesn't quite get the signal there. And so you're going to have a bladder that doesn't quite comply with what it should be doing, you know, because it's controlled by those nerves and it's disrupted. So normal urination may not occur because of that nerve damage. So we can see small bladders that result in uncontrolled bladder muscles. So the bladder is constantly going, and so you're constantly going to see urine coming out. For the smaller ones, what we don't want is for it to, you know, just be angry and doing this all the time and shooting urine back up into the kidneys. And then when it's doing this, if it's smaller, it can't hold as much, and you're also going to have the urine leaking out. Now, if it's larger, it can hold more, but there's the bladder, and then there are the muscles. It's called the detrusor muscle that actually allows the urine. It closes and it releases to allow the urine to come out. The bladder muscles cannot be controlled properly because of that signal being interrupted. And the same for the muscle. It could just be open and flaccid and just allows the urine to continue to come out. For neurogenic bowel, same thing. So you've just got that signal that goes to the bowel to say, you know, release the stool. It doesn't necessarily get there like it's supposed to. And so when it's not moving like it should, there can be the backup of stool in the bowel. And what we find is when there's a backup of stool in the bowel, if the child is loaded with stool, 9 times out of 10, you're going to have some bladder involvement, because you've got all of this impacted stool sitting on top of the bladder, just continuously pressing into the bladder, and the bladder doesn't like that. So we really try to make sure that we're doing toileting routines and bowel flushes, which I'll get to a little bit later, to make sure that that bowel is cleaned out every day, so that it's it's getting rid of the toxins. That's what, you know, elimination is for, and B, so it's not affecting that bladder. And so, as I mentioned before, we find that the continence piece and quality of life are so closely aligned, and achievement of that social continence results in a better quality of life. So, you know, it's associated with all of those things: the self-esteem, body image, independence, mental health, sexuality, the type of employment that the child's going to have as they get older. And so that's why we encourage, just like you would with your typically developing 3-year-old, you're going to want to try to toilet train. You're going to go through those steps. And even if we end up doing catheters, or we end up doing bowel flushes or medications to help the bladder hold the urine in, and then do catheters to release, that becomes their norm. But they're in control of it. They're in control of when they release the urine from their bladder, instead of having to wear something where they're constantly releasing urine, and then there's a smell, and then other kids notice, and then so on and so forth. You want to give them that independence to be able to have control of that, because in reality, when someone goes into the washroom, you don't know what that person next to you is doing. If you're out in public and it's got the stalls and someone else is in a stall next to you, you have no idea how they're relieving their bladder. Everybody pees. I tell kids all the time, everybody pees, everybody poos. This is just how you do it. Trying to make it, presenting it as, I hate the word normal. There's no such thing as normal. But I guess typically, how typically you would relieve your bladder or your bowels. This is just the way that they will do it, and just making that their routine. That's part of their routine. That's what they do. That's what they get used to. And we find that it's not that big of a deal anymore. And so, as I mentioned before, you can try the timed voiding, you can try the toilet training. There can be the catheterizations. Anticholinergics are just a medication that helps, as I mentioned earlier, when the bladder is spasming, it can just help relax the bladder and help it to hold that urine in. For the bowel, we can do stool softeners, laxatives, suppositories, and then bowel flushes, where it just will flush all the stool out at one point, usually at night. And then if it's the bottom half of the bowel is flushed out, then there's nothing to come out to have accidents during the day. So we clean that out as the child is eating, stool is moving down the bowel, there's nothing to come out because that lower part of the bowel is flushed out. And so that is to help, prevent the accidents. And then they control when they go, which is that night when they do their bowel flush. All right. So the musculoskeletal system, I'm going to be reading a lot of this because this is very much the PT's bag of tricks, but she helped me with it. And so it essentially consists of, your spinal cord, your pelvis, the femur, which is the larger bone, and the tibia and fibula and their lower leg bones, your feet, and then your joints. So your muscles attached to the bones, the brain sends messages to the nerves. Again, when that's disrupted, it can cause muscles to tighten or to be too relaxed. This is just a slide to show where the nerves affect. And so, in your child's diagnosis, if you have what level that their nerve tube defect is at, this is a general guide of what will probably be affected. Now, again, as I mentioned before, all of our kids are different. So you could have, a child with a thoracic level defect, but, they may not have any, symptoms in their back, or, you have, a child with the sacral, like, an S1, and they have no issues with their bowel and bladder. Like it does happen. But this, as a general rule, is where we find the nerves that affect the different levels. Okay, and so for people with spina bifida, the damaged nerves may result in inability or difficulty in controlling the muscles. Several ways is it doesn't function, and so the joint is loose. It functions, but it's weak, or the muscle only works at times when it's stimulated. And when it's a reflex activity, we try to make sure it's an actual movement and not just a reflex when we're diagnosing range of motion, because with each visit, when the child comes in, we do those measurements and we see, if there has been tightness or if the muscles are, improving with the therapy or with the bracing, so that we have that baseline at the beginning, and then we have the measurements after to see how they're progressing. All right, so some of the muscle conditions, again, you can have the weakness. You can have the paralysis where the muscles don't work at all. And so there's no movement or sensation. And then the contracture is what I mentioned before, is if there is one side that may pull stronger than the other, it can cause a contracture where the muscle actually can't be stretched. It's kind of in a fixed position. So it's important to minimize the contractures because they can interfere, as you could possibly imagine, when something is fixed, with any standing, walking, sitting, and then catheterizations as well, because you'd have to be able to maneuver to be doing the catheterizations. So something else we do see is different scoliosis in our kids, and that can be just the natural progression. That can be from them sitting in their chairs, and there's a lot of, maybe leaning to one side, or, improper fit of the chair. And so again, that's where that multidisciplinary team comes in to be able to, assess both the physical aspects and the equipment aspects of it. So it can affect your child's hips as well. And that comes into, when it comes to ambulation, the type of equipment that they may need to help them. And so again, it just goes from the level of where their neurotube defect is. So from S2 to S4, where kids usually walk without aids, but they may need just the little shoe orthotics, the flat ones that go into their shoes, just to kind of level out the foot and maintain a good walking pattern. From L5 to S1, they usually walk with AFOs, AFO is an ankle foot orthotic, so it comes to just below the knee. Usually they're rigid, like this. Sometimes they're hinged, but we usually prefer the rigid for our kiddos. And then they just wear those. They strap them on the foot. They strap them across just under the knee, and it helps them to maintain a good, safe posture. With L4, they can usually walk with the AFOs, but then for longer distances, they fatigue very easily. And so for longer distances, they will have a wheelchair. And then, as they get older, because kids get heavier, they may need to do braces for the shorter distances and still do the wheelchair for the longer distances. For L2 to L3, usually need the wheelchair for longer distances, and when younger, they may walk with braces at the knee and hip, and so braces can also go all the way past the knee up and secure around the hips. For T12 to L1, usually require a wheelchair, and when young, may walk at home for exercises with braces above the hip. And again, it comes into a safety thing, safety consideration, because at home where they know the terrain, it's flat, things are moved out of the way so they can move around, as opposed to when they get out, in the grass and you don't know about divots, and just maintaining, a safe environment for them to be able to move. Okay, so how can I help my child move and stay flexible? So again, your therapist are really good sources in the infant development specialists when we have the little ones up to age 3. So they do the assessments and provide you with suggestions. Sometimes they will do blocks of therapy if appropriate. And oftentimes it's the PT providing you with stretching exercises, and you do them at home. You make it into a regular routine, and then also with the bracing can help with their movement and their flexibility as well. So I want to end with just a couple of things here. We have a youth facilitator in our clinic, and that's the lived experience. She actually came through our clinic and aged out, and now is a part of our clinic. And you know, she knows the challenges, but just again, being informed, practicing that preventative care, it helps you to kind of, and having that support system will help you tackle, you know, the challenges that may come your way. Every parent wants your child to have a fulfilling life, to be happy, have friends, career, hobbies, relationship, whatever makes them feel comfortable. And so kids with spina bifida and hydrocephalus that grow into adults can have all of that as well. It's really important to connect with families that can share these experiences with you. So there is a spina bifida Facebook group. There is a spina bifida bowel management group. It's run by a group of parents, and I actually, for one of our bowel flush routines, use their pamphlet because it's so amazing. And then we have a spina bifida booklet available online. There's the link there. And then of course, Hydrocephalus Canada. So these groups give you access to the mentors, to parents who can share their stories, who can, you know, relate with what you're going through, who can say, you know, oh yeah, we went through that and we tried this and that didn't work, but this really helped. And it's good to know that, you know, they've been there, they've been through it, and they've come out, you know, on the other side and are in a good place. So I wanted to get just some final thoughts from parents and from a child that is now an adult. And so they were amazing and sent me these little bullets. She was fine with me putting her name in it. And so, yeah, she just said, you know, it's not easy, but it's an amazing journey. We feel blessed to have been chosen to raise an amazing human being. And she has made us and her siblings better people. Learn about spina bifida. All you can. We've always tried to treat Melissa like her twin sister. They didn't cobble her. Your kids, even though it may be challenging, they want to be treated just like you would treat your other kids, because they will see that and they will notice it. Yeah, let them try things, let them fail, and let them try it again. Don't compare to other children. When she hit milestones, they celebrated. They didn't stop doing things as a family because it might be harder, traveling, camping, etc. And then accessing the resources from our clinic and then from Hydrocephalus Canada as needed. And then for this young adult with spina bifida and hydrocephalus, yeah, remember to dream and to focus on your child's future. Ask questions, be their advocate. Okay. Yeah, we can do anything. We want, it just might look a little different. But again, these kids find a way. If they want to do something, they will do it. Take the opportunity to chat with other peers and parents. The Spina Bifida team or whoever your provider is here to help to make the journey a happy and fulfilling one. Set small goals so that your child can achieve them, and then you build on that. Try not to get discouraged. Things don't go to plan. Work on self-love and confidence, and work on being as independent as possible. And that's what we strive to give our kids, is that independence and those tools that they need, that when they go into adulthood, they've got it. And that's all. Thank you so much.
Thanks very much, Amy. Very interesting presentation, lots of good information. I have a question. We get a lot of questions about the MACE procedure and the Metrophenol for bowel and bladder management. Yeah. Is it common at the Spina Bifida clinic at Holland Bloorview?
So it is. So the MACE is the Mullin antegrade continence enema. And so essentially it is it's a surgical incision that's put into the upper part of the bowel, where you put a tube into the ostomy site. So it's a one-way site, and you will drain water into that tube. You sit on the toilet, and it essentially flushes your bowels from the top down. So the stool, you'll still evacuate just like you normally would, It's just the water helps move the stool all the way down. We also have something called a cone enema, or there's the peristine, which is called a retrograde enema, and it's from below. So it goes via gravity. There's a cone at the bottom that goes into the rectum. The water goes through the bowel. The difference between the two is that because it's via gravity, the cone only can get, a smaller portion of the bowel evacuated, whereas the mace, because it's coming from above, evacuates the entire bowel. And so you have less accidents because there's no stool there to come out during the day. Most of our families will do that every night, and that's their bowel routine. It takes about an hour to an hour and a half for the whole routine, to do the flush, and then you sit on the toilet commode, the bowels evacuate, and then you're done. For the Mitrofanoff, that is for catheterizing the bladder. And so normally what they try to do is get the end of the appendix to act as a conduit, and they put it in the belly button, so it can't really see it. And they make an opening in the belly button where you catheterize from the front directly into the bladder. So this is often our kids who have a hard time accessing being able to do the catheters independently from below, whether it be a scoliosis or a fine motor or whatever, they will access it from the front. And so they do the Mitrofanoff and catheterize directly from the front of their body directly into the bladder.
Perfect. Thank you so much for sharing that information. Just looking at the time, we are at 8 o'clock. So if there are any further questions, you can send them to info@hydrocephalus.ca, and I'll just put that in the chat real quick. And hopefully, if Amy's not too busy, she'd be able to answer them.
I would certainly, I'd be more than happy to answer them. I'm
Wonderful.
sorry, I went over. I didn't even glance down at the time.
It's quite all right. You had a lot of stuff to
There's a lot to cover.
talk about. Yes, there's always a lot to talk
it's
about.
It's complex, yeah.
Okay, well, thanks so much again. And thanks everyone for joining us tonight.